And let's get to diseases. I will make a general overview about the diseases from the nephritic spectrum and from the nephrotic spectrum, and then we'll talk in more detail about them. Okay. So you should imagine the glomerulus as we talked about, and now let's talk about the nephritic ones. And I'm gonna still divide them again as we did before. Nephritic and rather nephrotic. You know it's not 100%, but it's like this. And from the nephritic side, or in other words, the proliferative glomerulonephritis. Okay, so what you should remember over here is, first of all, those immunocomplexes. Okay, and I'm going to just name them and maybe tell a bit about them, and then we're going to go more deeply into their appearances and whatever. So with the nephritic syndrome, again, I'm going to put the proliferative glomerulonephritis. And first of all, remember post-infectious glomerulonephritis, okay? And by the way, because all of these, which I will, or almost all of them on the left side, which I will talk about, all of them can have different speeds. They can really kill the glomerulus very fast. And remember, the fastest speed, it's all about the RPGN, okay? So, and RPGN means rapidly progressive glomerulonephritis. And the thing you should understand, most of these can turn into this like boosted upgrade of the inflammation, but doesn't have to. But some commonly turn into RPGN, some don't, okay? So, first, remember PSGN, or poststreptococcal glomerulonephritis. And it's the immunocomplex, so immunocomplex problem where you create a special antigens against special molecules that the streptococci are releasing, and it's type 3 hypersensitivity, okay? And more we're going to talk later about this, but remember this one definitely in some few cases can turn into RPGN. So it's a really fast progression into end-stage renal disease. It's very rare that this post-streptococcal nephritis would turn into an end with end-stage renal disease. It's like only like 3% of the cases. So most of the diseases are light and self-limited. Remember this, okay? And typically it's 2 to 3 or 4 weeks after you're having a sore throat. It's late, post-streptococcal, post-infectious. That's the same. That's the synonym. So post-streptococcal. Then what you can have, and we talked about it already, it's the IgA nephropathy. And this one is very serious. So I'm going to put it in right. IgA, or Berger's disease. It's very serious because one half ends with end-stage renal disease. So half patients survive, half will have to wait for new kidneys. They end with transplantation. Okay, most common in adults, and basically this one could be most common in children. Yeah, so the post-streptococcal most common in children in a way. Remember. But IgA, some say 1/3 turns into end-stage renal disease, but it's serious. And again, you are creating IgGs against these special IgAs. We don't know exactly the cause, but somehow you're having an infection, and this is such a great contrast to the post-streptococcal one, because in this one, it's immediate. You're having an infection, typically like upper respiratory tract infection, and on the second day, suddenly you are peeing blood because you're having glomerulonephritis. And The thing we know why IgA, somehow your immune systems is creating defective IgAs. They don't have enough of sugars on them, and that's why your immune system doesn't like this, and you create a IgGs against these IgAs. Those are the immunocomplexes, and this destroys the kidneys. So, and this can really turn into the rapidly progressive glomerulonephritis. So really, like, you should imagine that the glomerulus is inflamed and mesangium is multiplying over there, and that there is really proliferation going on, okay? We got another IgA, which sort of could be related to Berger's, but it isn't. It's the vasculitis you know about. It's the IgA vasculitis. So another cause is IgA, watch out, vasculitis. And it's called the Henoch-Schonlein. And it's a bit similar to the Berger's Schonlein purpura. But you should imagine that they have a petechia because it's vasculitis, so they have petechias, and it's common in children, and it's, again, fortunately self-limited. Okay, so you have petechias, you can have purpuras, that's just more blood in the skin, and you could have some joint problems, and you can have a glomerulonephritis to it. And this is the glomerulonephritis connected with Henoch-Schonlein purpura. Or that's the older term. Today you are calling it IgA vasculitis. That's the nowadays term. And in most of the cases, the glomerulonephritis is lighter. It's light. But some cases can again progress rapidly. And some cases can end seriously, but only few of them, okay? Again, may present with RPGN, okay? So those are the ones you should know, and those are somehow connected with the glomerulonephritis. But then we have this another big group, and this is a very dangerous group and awful because most of them really kill your kidneys. And those are those special vasculitis that we're going to talk. The IgA vasculitis is a nice one compared to this one. And these all really, they have lots of to do with RPGN, so rapidly progressing glomerulonephritis. They all are about type 3, hypersensitivity, okay? And I'm going to name them later, but I'm going to tell you 4 of them, okay? And then you have, and I talked about it already, you have a special type, which is the type 2 hypersensitivity. That's the Goodpastures. And again, Goodpastures is mainly about lungs and kidneys. It involves only lungs and kidneys. And it's the type 2 hypersensitivity. And you are directly aiming your IgGs, your immunoglobulin, against the basal membrane of the glomerulus. Okay? So this is a direct hit. It's not about immunocomplexes, it's about direct antibodies. Okay? So these are the main ones from the nephritic part. So there's proliferation going on. On the other side, rather nephrotic ones, not all, but rather nephrotic. So no proliferation. So it's non-proliferative, rather. So basically, you should imagine the glomerulus, which looks like the one on the left, the normal one, sort of resembles normal one, and rather the changes are very small and are rather between the end feet of the podocytes, okay? So non-proliferative, or as we said, glomerulonephrosis, that could be a synonym to it. And what we will put over here, okay, so we got some systemic problems. So the systemic ones, and I told you already, but let's repeat it here. I'll put it in red because it's so systemic diseases, and that's the SLE. But watch out, SLE again. SLE, exception, nephrotic, but also nephritic. And it can also do really, let's say, rapidly progressing glomerulonephritis. So, like SLE can do anything, okay? That's SLE. But then obviously we got typically combination of diabetes mellitus and hypertension, okay? Then we have amyloidosis. And you should, of course, it's going to be either, and the more common one is connected with multiple myeloma. That's pretty common. And then basically any chronic disease as the AA you can mention over there. Okay, so amyloidosis. And then we can talk about some specific ones. So not a systemic, and Alport syndrome, that's inherited. There's a mutation of the 4th collagen. In Alport, there are more signs. So typically you can, if there's a problem with eye and ear, and there's some kind of nephrotic syndrome, rather, because Alport is causing the focal segmental glomerulosclerosis. So it's Alport. It's pretty simple, okay? And then you have kids, and I told you already, it's the minimal change disease. And this is only, they have a reasonable proteinuria, and the only change you can see is on the electron microscope. So, and it's a really good treatment. You give just corticoids, and in most of the cases, it's not serious, okay? So remember that. And still, one more comment on these. So it's the group of SLE, it's the diabetes and everything. But remember, typically with amyloidosis, or I can give you other examples. Remember, typically with amyloidosis, you're going to see large kidneys. I'm going to still mention more of them later, but remember already in amyloidosis, there's a large kidney. And basically, I can make a comment here, large kidney, because some exams ask for these. So remember, in amyloidosis, so on CT or ultrasound, amyloidosis makes a big kidneys, but don't forget also HIV nephropathy. And also the diabetes mellitus nephropathy. Yeah. And obviously, one genetic disease will always make kidneys very huge, and you all know it's polycystic kidney disease. Okay, so that's inherited, and they have huge kidneys. Okay. So this was a sort of a overview. Okay. Questions, guys?
Professor?
Yes. So, thanks for watching, and don't forget to subscribe and ring that bell. And as always, check the description below for supplementary questions and other materials.